Hello, my name is Jennifer Helm. I would like to thank my doctorate faculty chair, Dr. Rochelle Davis, and my community chair, Dr. Karen Welch, for their invaluable assistance. Welcome to the presentation of my Doctor of Nursing Practice, or DNP Quality Improvement Project, Reducing Turnover and Tension in Healthcare Providers Working in Southwestern Community Clinics through Self-Awareness of Compassion Fatigue. Introduction to the DNP Quality Improvement Project. After completing my Bachelor's of Science in Nursing, I worked as a registered nurse in the emergency departments and intensive care units of Idaho and Nevada. Since completing my Master's of Science in Nursing, I have been working as a family nurse practitioner in community clinics and nonprofit family practice in Idaho, South Dakota, and Texas. I currently work at a large community clinic in Central Texas. During a meeting with leadership at my current clinical practice, reducing healthcare provider turnover came up as one of the most pressing concerns. I was considering a few different ideas for my DNP Quality Improvement Project, and I decided to review evidence-based literature to identify causes of healthcare provider turnover. One intriguing and recurrent theme I found is that compassion fatigue is a significant cause of healthcare provider turnover. I've decided to develop a quality improvement project that would reduce turnover and tension of healthcare providers caused by compassion fatigue. My first goal was to describe the prevalence of compassion fatigue in Southwestern community clinics. Compassion fatigue is a widespread problem in healthcare settings. Multiple studies have found that the majority of healthcare providers experience compassion fatigue at some point in their careers. Underserved patients seen in Southwestern community clinics face many financial and personal hardships. Prolonged exposure to this vicarious suffering and stress leads to compassion fatigue in healthcare providers working with this vulnerable population. The second goal was to determine if there was a relationship between compassion fatigue and turnover and tension. The literature review reveals that compassion fatigue significantly contributes to turnover and tension in healthcare providers, and I wanted to evaluate if this was the case in my clinical setting. The third goal was to reduce turnover and tension. Up to 30% of healthcare providers in community clinics resign within the first year of employment. Adverse patient outcomes, poor quality of life for healthcare providers, and high operating costs for community clinics result from frequent healthcare provider turnover. Staffing shortages prolong patient wait times, which delays preventative care and treatment of chronic conditions. The remaining healthcare providers are assigned more work, such as refilling medication and reviewing the diagnostics of those who have resigned. This leads to poor work-life balance and increases the turnover and tension of current healthcare providers. High turnover rates increase operating costs of the organization. Recruiting and training new employees is expensive. Reducing turnover and tension will improve patient outcomes, healthcare provider satisfaction, and the budget of Southwestern community clinics. Compassion fatigue, or secondary traumatic stress, is a set of acute mental and physical symptoms that can occur after prolonged exposure to other people's trauma and suffering. It is often called the cost of caring. A common myth is that compassion fatigue only occurs in healthcare providers who treat critically ill patients. In actuality, all healthcare providers are susceptible to compassion fatigue. For example, I've experienced much higher levels of compassion fatigue working in family practice during the COVID-19 pandemic than I did during my years in the ER and ICU. My colleagues have made similar statements. Nearly every patient has high anxiety and stress that we are working with in addition to their acute symptoms or chronic conditions. Compassion fatigue affects most healthcare providers at some point in their careers. Compassion fatigue can also be seen in individuals of the general population. Symptoms of compassion fatigue can include feeling burdened by the suffering of others, blaming others for their plight, isolation, apathy, nightmares, dissatisfaction with one's work life or personal life, overeating, physical and mental fatigue, insomnia, loss of pleasure in life, difficulty concentrating, hopelessness or powerlessness, bottling up one's emotions, poor self-care, excessive drug or alcohol use, poor work performance, and denial. Methods of the DNP Quality Improvement Project. The literature review revealed that denial is a significantly problematic component of compassion fatigue. I could not find any studies specifically evaluating the effect of self-awareness of compassion fatigue on turnover intention. I wanted to determine if mitigating denial of compassion fatigue would affect turnover intention. I chose to pursue a quantitative descriptive pilot study. Participants were certified nurse midwives, nurse practitioners, physicians, and physician assistants. 22 out of 130 individuals responded to my email participation request sent by Dr. Welch, the Director of Primary Care, to maintain participant anonymity. 4 did not meet inclusion criteria. 7 participants withdrew, and their data was not included in analysis. 11 participants completed the Quality Improvement Project in its entirety. Participants were recruited from 32 Southwestern community clinics operating under one federally qualified health center. The ProQual is the most widely used compassion fatigue screening tool and consists of 30 questions graded on a Likert scale of 1, never, to 5, very often. There are 10 questions each to determine compassion fatigue, compassion satisfaction, and burnout. Participants will receive a score of low, moderate, or high in each category. Low levels of burnout and compassion fatigue are desirable. Moderate or high levels of compassion fatigue and burnout are concerning. Conversely, high compassion satisfaction is advantageous, and a low or moderate compassion satisfaction is troubling. The TIS-6 is a 6-item instrument graded on a Likert scale of 1, never, to 5, always. This tool has proven reliability and validity for assessing an individual's intent to leave a current position. The TIS-6 result is scored as high or low. The midpoint of the TIS-6 is 18, while the lowest possible score is 6, and the highest score is 30. The closer a score is to 6, the lower the turnover intention level. Participants received an email invitation to participate from Dr. Welch. I did not receive a list of potential participants' email addresses to maintain anonymity. A link to Qualtrics' online survey was embedded in this email. When participants clicked on the link, they viewed the implied consent document. They had to click I agree to continue the survey. Participants completed a screening questionnaire which consisted of 4 questions. If they did not meet the inclusion criteria, which was a healthcare provider, currently employed at the practice, between the ages of 18 to 89, and fluent in English, Qualtrics ended the survey. Participants completed the ProQual to collect burnout, compassion fatigue, and compassion satisfaction descriptive data. They completed the TIS-6 to collect pre-survey turnover intention data. Participants viewed a PowerPoint presentation on compassion fatigue as the educational intervention. This provided interventions on self-care to reduce compassion fatigue. A link to self-score the ProQual was provided so that participants would become self-aware of their compassion fatigue levels. Participants then repeated the TIS-6 to measure post-survey turnover intention. Results of the DNP Quality Improvement Project. In this graph, the x-axis demonstrates the three categories of the ProQual and the pre-survey TIS-6. The y-axis depicts the number of participants who scored in the low, moderate, or high range. The descriptive statistics demonstrate that burnout, compassion fatigue, and compassion satisfaction are prevalent in participants. The mean, median, and mode scores for burnout, compassion fatigue, and compassion satisfaction all fell in the moderate category. The mean pre-survey score was 15, which is at the higher end of low-level turnover intention. On this graph, the x-axis is the compassion fatigue score, and the y-axis is the pre-survey turnover intention score. You can see that as compassion fatigue increases, so does turnover intention. The Pearson's correlation coefficient analysis was used to determine if there was a relationship between these two variables. Statistical significance is achieved at the 0.05 level. The p-value for this test was 0.045. This result is statistically significant and indicates a positive correlation between compassion fatigue and pre-survey turnover intention. On this graph, the x-axis is each participant, and then on the y-axis, this is the pre-survey and post-survey scores of the turnover intention scale. You can see that half of the participants did demonstrate a decrease in post-survey scores. The other half were unchanged, with one individual demonstrating a slight increase in the post-survey score. The mean survey score was 15, and the mean post-survey score was 14. The Wilcoxon signed rank test was utilized to compare these scores. The p-value was 0.096, which demonstrates a mild decrease in post-survey turnover intention, but it is not statistically significant. Discussion of the DNP Quality Improvement Project. Only 11 participants completed the entire quality improvement project, and a small sample size can limit the validity of a study. I attempted to maximize the number of participants by asking Dr. Welch to send a follow-up participation request 1 week after the initial email was sent. Participants were self-selected, which can lead to selection bias. With selection bias, it is difficult to determine if results are due to the independent variable or pre-existing factors. For example, apathy is a common symptom of compassion fatigue. Apathetic healthcare providers experiencing high levels of compassion fatigue may have declined to participate in the quality improvement project. However, I did not have the authority or the desire to mandate participation. When I was researching methods to address turnover intention caused by compassion fatigue, I noticed that denial was a significant component of compassion fatigue. However, I could not find any studies that specifically focused on the effects of self-awareness of compassion fatigue on turnover intention. Most interventional studies focused on self-care, such as proper diet, exercise, sleep hygiene, socialization, hobbies, mindfulness meditation, and yoga. These methods all seem to be effective methods to reduce compassion fatigue, and I included this information in my educational intervention. However, I was curious to see how much of an impact self-awareness of compassion fatigue alone would have on turnover intention. So I designed this quality improvement project as a pilot study. However, pilot studies do not typically have generalizability, and further research is needed. All 7 participants who withdrew did so after viewing the educational intervention, but before completing the post-survey turnover intention tool. Participants likely believed they were finished when they saw the reference slide. In future studies, I would specify the steps at the beginning of the survey by stating, you will answer a survey, view a PowerPoint presentation, and then complete a final study. The timing of the quality improvement project may have been another factor. The Southwestern Community Clinic was changing to a new electronic health record, or EHR. I timed the quality improvement project to conclude 2 weeks before go live. However, training for the new EHR was running concurrently with the quality improvement project. Participants were able to complete the quality improvement project at the time of their choosing, and I thought that would be sufficient to avoid loss of participation due to EHR training. In hindsight, potential participants may have been declining due to the increased workload from the mandatory EHR training. In future, I would conduct the quality improvement project when there is no mandatory training. No incentive was offered during this quality improvement project. Next time, I would try offering a gift card to see if that would increase participation. Compassion fatigue, burnout, and compassion satisfaction were moderately prevalent in participants. This is problematic because compassion fatigue is detrimental to healthcare provider retention, job satisfaction, professional ability, patient outcomes, and personal lives. Healthcare providers experiencing compassion fatigue may become dissatisfied with their work and seek other employment opportunities, which can be costly for Southwestern community clinics. Compassion and empathy are essential qualities of healthcare providers. A decrease in compassion and empathy can negatively impact the healthcare provider-patient relationship. For example, a diabetic patient may be less receptive to half-hearted counseling given by a healthcare provider suffering from compassion fatigue. This can result in adverse health outcomes, such as poor glycemic control. Poor patient clinical outcomes affect the Southwestern community clinics as well as the patients. Insurance reimbursements can be lower for healthcare organizations that are not meeting standards, such as hemoglobin A1C goals in diabetic patients. If patients do not feel the healthcare providers care about them, they may seek healthcare elsewhere. Healthcare providers are typically compassionate, empathetic people. Suffering from compassion fatigue can lead to poor quality of life and decreased self-compassion. Healthcare providers suffering from compassion fatigue may become disillusioned, dysfunctional, depressed, anxious, self-loathing, and just dissatisfied with their lives in general. As a participant's compassion fatigue increases, so does the intention to leave the current job. Untreated compassion fatigue worsens over time. If compassion fatigue is not addressed at the Southwestern Community Clinic, it will lead to high turnover intention. Self-awareness of compassion fatigue produced a modest decrease in turnover intention. One must identify a problem to address it, and education is an excellent first step in combating compassion fatigue. Leadership must address healthcare provider turnover caused by compassion fatigue. The Quality Improvement Project demonstrated that compassion fatigue is prevalent, and there is a positive correlation between compassion fatigue and turnover intention. Most participants scored in the higher end of low-level turnover intention. This suggests that participants find their work meaningful, but are experiencing symptoms of compassion fatigue. They're likely not actively searching for a new job, but are not completely satisfied. If compassion fatigue is not addressed, it will increase, and so will the healthcare provider's turnover intention. Healthcare leaders must promote compassion fatigue education. CME sponsored by the State Board of Nursing and Medical Board would be beneficial. Compassion fatigue education should be incorporated in healthcare providers' training programs. You cannot treat a problem if you do not know it exists. Leadership at Southwestern community clinics should incorporate compassion fatigue education into annual competencies. This will be a cost-effective way to improve healthcare provider retention. Although not statistically significant, self-awareness of compassion fatigue did produce a modest decrease in turnover intention. Further research into the effect of self-awareness of compassion fatigue on turnover intention is needed. Most participants reported a moderate level of compassion fatigue, which is concerning. There was a positive correlation between compassion fatigue and turnover intention. Addressing turnover intention caused by compassion fatigue is essential. High turnover rates of healthcare providers are associated with poor patient outcomes, increased financial burdens on Southwestern community clinics, and poor job satisfaction in the remaining healthcare providers. Denial is an insidious component of compassion fatigue, and many individuals are not aware they are experiencing compassion fatigue. Self-awareness produced a modest decrease in turnover intention, and education is an essential first step in reducing healthcare provider turnover intention caused by compassion fatigue. However, further research is needed. Thank you for viewing the presentation of my DNP Quality Improvement Project, and here are my references.